Hi, this is Adam J. Brown. Welcome to my next case presentation, Making the Puzzle Pieces Fit. We have a 71-year-old male who presents for evaluation of peri-orbital edema, fevers, night sweats, rash, alongside a 30-pound weight loss over 3 months. Peri-orbital edema was initially unilateral, progressed to bilateral. During the workup, he was found to have bicytopenias, a low white count, low ANC, low hemoglobin with an elevated MCV, but normal platelets. The dermatologist consult did a biopsy showing neutrophilic dermatosis of his upper back. Malignancy workup found CT scan of his chest, abdomen, pelvis, revealing splenomegaly. Bone marrow biopsy was done, revealing hypercellularity. So from a rheumatology perspective, when we have peri-orbital edema, the differential is fairly narrow. You know, is it infection, is it malignancy? If those are ruled out, then the concern is something that can add tissue from a rheumatologic perspective, which is actually not very broad. So we have IgG4-related disease, we have sarcoidosis, we have granulomatosis with polyangiitis. His ANCAs were negative, his IgG4 levels were normal, and his CT scan of his chest was not evidence of hilar adenopathy. So the patient's actually given high-dose steroids, 60 milligrams, and voila, he felt great. Peri-orbital edema resolved, cytopenias improved, fever completely resolved, but he didn't have a diagnosis. They tried to taper the prednisone when he left the hospital, and by the time he got down to 40 milligrams, something new happened. He gets ear swelling and pain and redness. That's new. So finally he gets brought over to the Cleveland Clinic. What do I have? What do I do next? I can't get off the prednisone. So peri-orbital edema, fevers, cytopenias, and auricular chondritis. What is this? What ties this all together? Well, we have VEXAS, vacuoles E1 enzyme X-linked autoimmune somatic. Somatic mutations in the UBA1 gene, which could result in a constellation of symptoms, typically in patients in the age of 70 or above, but can be seen even younger than that. Fevers, they can look like relapsing polychondritis, like our patient dad. They can look like giant cell arteritis. They can look like polyarteritis nodosum. They can have peri-orbital edema. They can have myelodysplastic syndrome-like disease, i.e. the cytopenias. His bone marrow was not atypical. He did not have the vacuoles they typically see on bone marrow biopsy, but the patient still has the genetic confirmation of VEXAS. Thanks so much for listening.